Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care is the way. I am Dr. Ryan Neuhofel of NewCare, and this is my DPC story.
Dr. Ryan Neuhofel is a board-certified family physician. He was born, raised, and mostly educated in the state of Kansas. He received a BS in biology from Friends University and Master of Public Health from University of Kansas prior to medical school at Kansas City University. He completed his family medicine residency training at KU Med, where he served as chief resident. Shortly after finishing training, he founded NewCare in 2011. He now lives in Lawrence, Kansas with his wife, 4 kids, and 1 Labrador Retriever. When not cleaning up after his children or a dog, he enjoys cooking fine ales and the great outdoors. Welcome to the podcast, Dr. Neuhofel.
Thanks.
You know, that we're recording this, unfortunately, past May the 4th be with you, but I love it. This is the way, people. And that is not even something that you can take lightly. When Dr. Neuhofel opened his practice over a decade ago. So that is incredible, in 2011. So let's start there. Back in 2011, you had opened pretty much out of residency. And we hear people doing that more and more these days, but this is 2023. So back then, did you even, think about fee-for-service as an option after residency, or did you always want to do a non-fee-for-service model practice?
Yeah, well, first of all, thank you for making me feel very old. So I'm sure my story changes over time because you get older, you reflect on it and try to remember what you were thinking at the time. But I the way that I remember it is towards the end of medical school, which for me would have been 2008. Makes you feel even older. I knew that I wanted to do primary care, but I just didn't see a way that I could do it in a way that I envisioned myself being a family doctor. So I wasn't in a state of despair about that because I knew I had to go to residency and I didn't have to decide tomorrow. But when I looked at what my career path or what my 5 or 10 year plan was, I knew, man, I don't know what I want to do when I grow up. And so, I went to family medicine residency. I knew I would have to just do what everyone does. But I know by the time I was an intern, I knew I wanted to do some type of alternative practice model. And I think I read a few articles, 2008, 2009. I think Dr. Garrison Bliss in Seattle was the first one I read about and thought maybe this is something that I could do. And so I did a little bit of research, but there wasn't many people doing what we now call direct primary care, and certainly using the phrase back then. I think there was only a handful of mentions on the internet in 2009, 2010. And so really my second, third year of residency, I kind of formulated a business plan and wrote that all down and spent my little free time in residency getting ready to open my practice. So I never took a job or worked in any other setting outside of, residency in primary care. I did a lot of ER moonlighting for financial reasons, but no, I never worked in a fee-for-service and never considered it, and started my practice about 6 months after I graduated residency in December of 2011.
It's incredible. And I want to go into you planning to open back in this day where there weren't a lot of DPCs and people didn't even know the term DPC. When you say you prepared, what did that actually look like for you? Because there wasn't, like the bagel, checklist, how to open your DPC.
Oh goodness, no, there was literally nothing. I mean, again, my memory might be a little cloudy on this, but I think there was literally only a handful of mentions of, quote, direct primary care on the internet when I launched my website in 2010 or 2011. There's a couple news articles, but really there was no brand. I'm not even sure the legally there had been mention of direct primary care in the Affordable Care Act, but like in a public sphere and a business sphere, it really wasn't a thing. And so really there wasn't a lot of resources. So I read a lot of stuff just about entrepreneurism, small business resources, and talked to a handful of doctors at that time. But really, we were, especially in those early days, really making it up. I know we're still doing that to a degree, but there was no recipe, there was no checklist, there was nothing. So I think just learning to be a good small business owner and entrepreneur back then was the most important thing. And I still think it is. I think that's, although it's amazing that so many resources exist now, I think we should be still aware that being a good entrepreneur and good business owner is required. It's not like you can just get a 15-point checklist and be a business owner. So, but yeah, back then it was like there was no recipe. There was no one really to look at and say, oh, I know this is going to work, because we were all very, very new.
And that's a nice play off of your name. Pretty good. So when you talked about how for financial reasons you were working moonlighting shifts, doing ER, it was great also that you were doing that for your experience going into a private practice where you were a private doctor without, having years in fee-for-service before jumping out into your own practice. So can you speak to this fear that some people have about, well, I can't open after residency because I don't know enough to be able to practice on my own?
Yeah. No, I mean, residency prepares you to a degree in terms of your knowledge base, but it doesn't feel real in many cases, because you have, especially if you're in a bigger hospital, academic setting, like I finished my residency in. So I really learned how to be a doctor probably in the ER my third year of residency, because I like money. And so I worked a lot my third year of residency in moonlighting because I had the opportunity to. So I really do think that was crucial in helping me. I was going to do it one way or the other because I'm unemployable, but I really do think it made me more comfortable, because being in the ER in a rural setting, which is where I worked, there is no resources. I mean, you are on your own. Even if there are other doctors in town who are on call, they don't answer their phone. So you quickly learn to be comfortable on your own in that setting. And I think in DPC, you have to a little bit as well, because you're not going to have an army full of people helping you most of the time in a DPC practice, especially if you're opening your own. So no, I think that was super important and allowed me to care for people at a higher level of illness or acuity, and allowed me to be comfortable with that. And that's the huge value of DPC. If I practice medicine just like people in a traditional fee-for-service model, then it wouldn't be as valuable. So I don't tell people I'm an emergency room or can provide the same level of service, but I do think I'm able to be more comfortable caring for things that I wouldn't have been able to otherwise.
And I'll just put in a plug here, especially for family practice doctors or people who are applying for family medicine residency. That's a reason to look for an unopposed program. And for those listeners who might not be aware, there are opposed and unopposed programs. And the unopposed basically means that the family medicine residency is the only one in the hospital. And so you pretty much do all the things. And so especially if you're thinking about how could I develop confidence to do DPC, that's one way to strategize about it and go to a residency where it's all you as a family practice doctor. So with that, you have this training and this confidence underneath your wings, and then you open. And in Lawrence, because DPC was not a thing really back then, what was the adoption like in your community? Did, on day one, you have 100 people in your practice?
I got lucky in some respects. I got, a couple news stories, I think, like the week that I opened or the week before. So, I mean, I think a lot of buzz even in the first couple of months. And I think the first month I signed up like 20 or 30 patients based on a news story. Now, I'm not sure everyone really understood what I was doing. So I say I had, 30 patients in my first month. I think, half of them within a month quit because they were like, wait, I have to pay every month? And I'm like, yes, it says that, So I thought, I had an amazing start, but, it really took me a year or two, I think, to really like even come close to breaking even financially. So I had, some early nice media success, social media. I was very active on social media back then before I hated it. Well, I probably even did hate it, but it was more of a necessity. So yeah, I mean, in terms of direct primary care, there was no brand. So I used the phrase a lot when I was talking on social media more broadly to people interested in healthcare topics. But locally, like, I'm not even sure my patients could have told you I was DPC or direct primary care. So I use the term on my website, but, I use the term membership medicine or, membership based practiced a lot because people understood that, whereas DPC wasn't really defined. So even today, I'm not sure that my patients have this strong connection to the brand or the phrase DPC. That's kind of like what I talk about with my doctor friends, and they all know what that is now. But my patients just know us as New Care or Dr. New or whatever, and they know they pay a membership fee.
I love it. And as you had those 20, 30 people join the practice and then you grew from there, did you get a consistent increase in patient members, or did you have an ebb and flow?
Oh, yeah. Yeah. Ebb and flow still to this day. I'm 11 years in and there's ebbs and flows. And sometimes it might be something I did, but sometimes it's just random. I mean, the pandemic has definitely like thrown a lot of stuff in there. But yeah, I mean, even in the first 6 or 8 years when I was pretty much close to my own personal capacity, we would get some months we'd get, 4 signups, and other months we'd get 15 or 20. And I wasn't marketing more heavily those months. There may have been some seasonality to that, but I think month to month it can be hard to judge things, whereas you can start looking, quarter to quarter, year to year, it starts making a little more sense. But even then, I'm not sure.
And when you mentioned the pandemic, because you were clearly open before, during, and now after the pandemic has quote unquote ended, when it comes to DPC, and no matter what your patients understood it to be, they knew that it was care with Dr. Ryan Neuhofel.
Mm-hmm.
How did you view DPC in terms of DPC is robust because of, XYZ examples, or DPC was so valuable to your patients because of, this type of evidence?
Yeah. I mean, I think from a day-to-day standpoint, it really wasn't as much of a learning curve for us. I know that the entire healthcare system was in disarray trying to figure out how to do, quote, virtual care or, quote, telemedicine. But to us, that's what we've always done, because even, day one, I would always start with a phone call, text message, or email, and then escalate it to an office visit if needed. So we've by default been virtual based, or whatever you want to call it. So really, we didn't have anything to really learn or work out. And so for our patients, nothing really changed. They text message and emailed us with a concern or problem. And if I could solve it that way, I did. And so our clinic never had to really deal with that growing pain of figuring out how do we care for people when they can't come into the office. So yeah, so I think for both us and the patients, that was nice. And from a business standpoint, because we're membership supported, I didn't really have to worry about, number of office visits per day. I got paid the same, 3 months into the pandemic, my revenue was pretty much the same as it was 3 months before the pandemic began. And I know, especially my primary care friends who were in traditional practices, I mean, they were on the verge of bankruptcy after 3 to 6 months because their revenues just went down so much. So yeah, I mean, the pandemic was definitely, not to say that the pandemic wasn't challenging. We were trying to figure out, like everyone, how to get testing supplies and PPE and all the other stuff that other doctors were dealing with. But from a business standpoint, it was easier for us, I think, to adapt.
And in terms of the members at your practice, how many members are individual members or family members versus
I don't have
employers?
those stats off the top of my head, but I would say, we have kind of 2 key demographics. I would say we have families with children, under 25. We have a lot of like larger families, or a better deal for larger families. And then we have people who I would call, or the pre-Medicare patients. So between, 50 and 64, who have a lot of chronic illnesses. So I think that those 2 demographics make up probably 80% of our patients, if I could categorize them. But we really run the gamut. We are more uninsured, I think, as a percentage than most DPCs, but I know a lot of DPCs care for uninsured or, quote, underinsured patients. So yeah, so I think we kind of run the gamut of people. And I think most of our uninsured people are self-employed, small business owners or artists. I live in a college town, so there's a lot of starving artists and musicians. So I think that those kind of describe my practice demographics as well as I can.
That's awesome. And, I'd love if you could touch on your advocacy as well as your participation in like RIP medical debt, and just how you talk to people about like DPC is not for the rich. It's not exclusively for the rich, I should say.
Yeah. I mean, I've been beating that drum since 2011, 2012, trying to clear up that confusion, if I'm being nice to the critics about this. And I think there are some people who are just literally confused. They've never heard of DPC, and then they conflate it with concierge, and then the connotations are there. So I think some people are like literally confused or just unaware. And so I've spent years, long time ago, writing about that and talking about that, about my patients and my practice, and and helping, people do some research on these topics. And so, I think that that's been, the evidence that isn't the case has been clear since 2016, 2018. But yet to this day, I still hear people say it. And so some of those people, again, are just completely unaware of DPC. Some people, even despite seeing the evidence, still say it for whatever reasons. I can speculate as to why they want to continue to say that. But I think people in the DPC world know that that's not the case. And I don't,
Absolutely.
I increasingly am, I guess, unconcerned that there's people trying to spread misinformation because we can't stop them. I mean, so as long as we continue to grow our practices and movement, I don't think our patients care about this. I think this is like, people in academia, turning their nose up at something that they don't understand, and no one's paying attention except for us.
Recently, there was an article that was written by Hunter Schultz where he was talking about venture capital and direct primary care and where the two meet in the road, and then, going forward, what can happen if the two interact. And so recently we are very much aware in the DPC space that, as Dr. Doug Frago calls One Medical a DPC in name only, when venture capital comes on board, do you see that being successful? As Hunter Schultz pointed out in his article, that he, from what he was presenting, that's a very skeptical thing to see, where venture capital can continue to honor the autonomy that we have as physicians, as well as the autonomy that our patients need to be able to access transparent pricing and transparency without somebody dictating who can have what.
I haven't read the article, but so I can't really comment on that. But on the topic, I mean, DPC, for the most part, I know there's a few examples of something to the contrary, but for the most part, the DPC movement and the bulk of the practices and patients served by it are made up of really tiny small businesses like mine. And so I think in that setting, venture capitalists have never offered me money, nor do I think they're going to offer any other business, a small business whose revenues are probably well under $1 million, venture, money or investment, because it doesn't really make sense. I mean, venture capitalists, early stage investors are looking for a 10x or 50x return on their money. And that's, I would say, literally impossible at a local small practice level. So in some respects, I'm like, it doesn't matter to us. Like, I don't know anyone who's legitimately trying to do that with their practice. I think most of us, even if we're trying to conquer our universe, it's a pretty small universe. I know that companies serving DPC practice need investors, right? And so there are some large companies, whether they be, software or some other support service, that are serving, hundreds or thousands. Like, yeah, I mean, it makes sense for them to get investors. And I don't view that as a threat to the DPC movement any more than, purchasing medications from a giant corporation to sell to my patients at wholesale prices is a threat to the movement. I do think it gets a little bit, there's at least some potential moral hazards if someone is trying to start a, huge corporate version of DPC, meaning that there's like one company and they own hundreds or thousands of locations. One Medical, just to comment on that, is not DPC. They're not only not DPC in name only, they're literally just not. I mean, they bill insurance plans, they contract with private insurance plans. So I don't even, like, I know in the media sometimes they label them that, which is very confusing because One Medical's never used the term. I don't even know how that got started, to be honest. So they're an insurance-based practice that charges an extra fee, which is more similar to what concierge doctors or MD VIP, which is one brand of concierge. So I don't even give them the credit of calling them a DPC in name only because they don't use the term. So yeah, I mean, I get people's concerns because I am a fiercely independent doctor and business owner. But at the same time, like, I don't think investors are able to like disrupt these individual practices because they're not going to offer us money. I'm not going to give them a 10x or 100x return on their investment.
You could on Band-Aids. Like I fill my cart with extra Band-Aids when I need to fill up my cart to get free shipping. But I'm really glad you touched on what you did, because at the DPC Summit, last weekend, it was interesting to hear some people talk about like, well, maybe I should join a place like One Medical or a place like MD VIP versus opening a DPC or joining a DPC. So it's interesting that, where you started, the DPC wasn't a thing. And then now people are having that type of
well,
thought.
those, yeah, I mean, even those two companies, which I don't want to belabor, give them too much airtime. I mean, some of those are like One Medical is an employer, right? So being an employed doctor in a big company is just a totally different thing. And there might be opportunities for, there are increasingly opportunities for doctors to be employed by a DPC practice. Most of them are pretty small businesses and practices. So yeah, I mean, I think you get down to this, and I've heard this since 2012, 2014, even we were, growing back then. I was happy. And I think when we officially had 100 DPC practices nationwide, and what I heard back then was, well, this is cool, but it's never going to scale. And then we got to 500 and people said, this is cool, but it'll never scale. Then we got to 1,000, heard the same thing. Now we're at what, 2,000? I don't even know what the number, but it's cool, but it'll never scale. And so I don't even know what people mean by that, frankly. I don't know if they think we're going to go from 1,000 to the majority of practices overnight. Like, I don't know what people mean by that, but I've been hearing that since there was 10 practices or 100 practices at DPC will never scale. And yet there's more and more and more and more of it. So maybe that's not scaling. Maybe that's like gremlins or something. We got wet and spawned each other off. I'm not sure. Again, I'm old. I know the young people won't get a gremlins reference, but to me, that is scaling. It's an organic movement of a bunch of independent businesses, and maybe venture capital don't like that, right? Because how can you make money on a cottage industry, right? You can only make money if it's a one collective that all the money goes into. So investors probably aren't interested in a cottage industry, but that doesn't mean there's not going to be more cottages, and there are more cottages. And so I don't know like what that means. Is DPC going to be 50% of the primary care market? Probably not. And that's okay, because I don't think anyone has a specific goal there. I certainly don't, but I don't think that means really much if we continue to have practices open and be successful.
And even like you spoke about your patients, like they might not know exactly like what the legal definition of direct primary care is. And to them, they just know that they can pick up the phone and get a hold of you. And that's what makes the difference. And that's why, if you're thinking about DPC and you're on the fence about like, what is DPC? Can DPC survive? It's like, you have been open since 2011. That is flipping amazing. So, I put that out there, especially for people who they got some enthusiasm, but they might have some fears making the leap into DPC after attending DPC Summit. So one of the things I love about you, and I remember this from the 2019 summit talk that you gave in Chicago, you had a picture of like your snazzy hat and you're in your white coat in front of the porch. It was super awesome. I love that picture. But you do home visits, and like, that's a thing that you can do because it's your practice and you can do whatever the heck you want. So can you talk about how did you start incorporating home visits, and was that part of your training and so you just continued it in your own practice?
Yeah, I think the closest I came to like home visits was visiting in residency, was probably doing like assisted living or people who were in a retirement community. We had a few patients. We would do a few of those. I think in residency, we did a handful, but no, I didn't really get much training on that. But, I think that in someone deciding how to form their practice, if that's something they think is valuable and it's something they're comfortable doing, like you can do it. I mean, that's the cool thing about DPC is, we say it's this model and movement, but it ultimately comes down to a lot of decisions for the doctor and what they want to do. And so, not all DPC practices do that. I do them. I don't do them frequently. I don't want to drive to someone's, house who just has a sore throat. So it's not a convenience thing. It's more of like a need thing. So if I have someone who's, post-op or, a newborn baby or someone who's truly homebound, then we do those. But I don't even do a ton of them. But I know that my patients know that is an option if it's needed. But, you have to use judgment in that in terms of whether you're comfortable to do it. So I've had many doctors say, like, I'm just not comfortable. I'm like, well, don't do it then. It's like, it's not going to make or break you.
I totally agree.
And I've had to tell patients who requested them, I'm not comfortable. So we all have to use discretion, same as we do a procedure, same as we do anything else. So I don't want people to think like you have to do house calls to do DPC, but it is great marketing if you do them.
I love it.
Even if you do like one a year, it's great marketing.
That's awesome. And yeah, I think about, there was a person in town whose spouse needed a letter, basically signed, a form filled out for the VA to extend his benefits to his spouse. And there was no doctor who would do a home visit, and they don't have a primary who in fee for service would go to their house and fill out the papers. And the spouse was unable to physically get to a doctor to have the papers filled out. And so like that, I get into the one-off services, but when I talk to people about, they ask me, do you offer one-off services? I do, especially for things like that, where it's like, sure, I have availability. Oh, a lot of it, because most of my care is, virtual first, and then patients are seen in person if I have to. But when you think about, autonomy, I am so glad that you mentioned, like, if you're comfortable with it, because we just had a whole talk on boundaries at the DPC Summit.
Sure.
And that is absolutely something to, keep you safe. And that safety is not just physical safety, but that safety also extends to, mental safety when you're, stressing about like, oh, can I do this? I don't know if I've done this enough times to be able to do it on my own, blah, 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 blah. You have to listen to that voice before you do anything in medicine. And so I think that that's super important. Yep. And when you have done home visits, because again, you've been in practice for a long time, do you have any favorite home visit bag hacks for those people who are interested in home visits?
It's funny. So I have like my logo is literally a doctor's bag. And so I feel bad I don't do more house calls because it's literally my logo. But I just think it's such a cool nod to doctors of a different generation. But yeah, I mean, I have like an empty black bag and it sits in the corner of my office. And so I'm not usually going to do more than one house call at a time. So I usually kind of know what I'm getting into and I'll throw whatever supplies and stuff and equipment I need in the bag. So yeah, I don't know. I mean, it just depends on the circumstance. Like, if it's like a newborn exam, I sometimes will ask them, do you have a scale? If so, what type? If not, I'll throw my scale in there. But I basically bring whatever I know is needed and, maybe a few extra little things that may come up. But it's usually a pretty simple thing. Stethoscope and a light will get done most of what I need.
I loved when we were at Dr. Esther Katibi's talk about at your cervix and just women's health.
I didn't see that one, but I love the name of that. I'm sad I didn't see it because I love the title so much.
It is awesome. And her story was that she got it off. She was inspired because of a patient giving her a mug that said at your cervix. And so, but I loved how Dr. Jeff Davenport was saying, little hacks that he had, like, if he could not reach the cervix, one tool that he had was like a ringed forceps to basically be the extender for the tool or Q-tip that he needed for the cervix. So, it's pretty cool. But yeah, it definitely, if you are wanting to do home visits and you talk to people like yourself and myself who do home visits, ask that question, like, what do you do in this situation? Like, hashtag, you can use a Q-tip for a pap smear if you forgot your pine cone bristle.
Well,
or
I have not.
to
clarify, I've never done a pelvic exam or a pap smear at a house call. That would be a little bit challenging for sure. So again, boundaries, but no, I think it's cool. Like I've seen so many innovative things come out of the DPC movement, and some doctors might look at it and think, man, those people are just cowboy wackos. But I think when you remove yourself from kind of a system, you just think more creatively, and there's so many cool things, whether they procedures or techniques that aren't necessarily, they're not invented in the DPC movement, but there's these like little cool things that like I didn't hear about in medical school or training. And then, I learned about it from someone at DPC. I'm like, man, that's awesome. That should be the standard of care for whatever that is. So whether it's like a new procedure or a different way to do a procedure. And so I think for whatever reason, because DPC, maybe we have more time or because we're more open-minded, that we kind of discover these things and share them. And so that's one of the coolest things clinically is like, I've heard of, some cowboy tricks that I'm like, man, that is awesome. I wish they would have teach that in residency, but I didn't learn about it because, whatever reason, I don't know, maybe it just wasn't in the textbook or whatever.
Absolutely. And, I came from a point of care ultrasound class in Portland a couple of weeks ago, and I heard crazy things like, don't put Tegaderm on your ultrasound probe because it'll ruin it. And again, there's going to be people who disagree with this, but I will say that the instructors were like, well, I use Tegaderm every day and I'm still rolling. So it's pretty okay. Yeah. I love it because, I mean, you're right. When we have the time, I feel like we can think about things differently. Like, I mean, I've had to do so many different types of procedures in people's homes because I was exclusively home visit and telemedicine based my first year. And so like there's ways to, maintain standard of care, but do things so it works for your patient, it works for you, and you're not, putting anybody in bankruptcy and you're not spending a ton of money to do the things that you need to do. So I think I encourage people to ask others how they do home visits if they are interested. And let me ask you now, going from home visits to your brick and mortar space, you have Ashley, and then you also have Jessica. Yeah, you also have Jessica. Yep. So when you opened, it was just you.
Literally just me. I didn't even have a nurse. I had someone who would come in a couple of days a week, but it was literally just me because I didn't have any money to pay anyone. I was working at the ER to pay my rents. So you're much smarter than me. See, the younger generation gets smarter and decides to start with just a house call virtual only. But I thought I needed a brick and mortar place because I'm like, I'm crazy enough. If I don't have a brick and mortar place, then no one's going to take me serious. And I don't know if that's true or not, but that's what I decided. So Yeah, I didn't have any staff full time in the first year. So I was doing, pretty much everything, all the admin, all the nursing type stuff. And then, I hired a nurse part-time that came in, I think 10 or 20 hours a week, but I was, there a lot by myself. And so, as I grew, I was able to pay, a nurse. And over the years, I've had, I think, 3 full-time nurses in 11 years. And then probably 5 or 6 years ago, I hired a nurse practitioner because I'd been at my, kind of, capacity for a while and wanted to dedicate more time to doing other things. And so, yeah, still to this day, 11 years in, I have 1 full-time nurse. She serves so many roles, the office manager in some respects and does our supplies and a lot of our billing stuff. It's just awesome and does pretty much everything. I always joke that I just like show up occasionally and let Ashley do everything. And I just sign paperwork. That's all I really do at this point, which is your goal as a doctor, right? I'm worthless except for my signature. And then, as I said, 5 or 6 years ago, I hired a nurse practitioner, Jessica, which is great. She had done some covering for me when I was on vacation and stuff, because when I was solo practice, I wanted to have someone available, at least for part of the week for my patients in case they needed something. So Jessica had worked for like 2 years, I think about a year or two when I was on vacation, and just everyone really liked her and was awesome. And wasn't planning on like hiring her full time as a provider and having her own panel, but she was just great. And I know there's a lot of debate about the nurse practitioner physician thing there, but she just was so great. And the more I got to know her, I was super comfortable with her, coming on board. And so now we can kind of share vacation time. So we keep our own panels though. So I have my panel, and if I'm here and not on vacation, then I take care of everything and she takes care of her patients. So, we don't really share patients in that way. And I think that for us has worked out really great.
Awesome. And let me ask you there, when you opened, because you were a solo doc at the time, and now you have 3 people, including yourself at the practice. Mm-hmm. Have you moved, or have you always been in the same space?
I moved one time. Yeah. So my first lease, I think, was 4 years. And I think about 4.5 or 5 years, I moved into a new space because we just need a little bit more space when I brought on Jessica, and I wanted to expand into some other, wellness, fitness services and stuff. So I wanted to be closer to my house. So I found a new space that was closer to my house. And so, yeah, I've been here since I think the 5th or 6th year of practice, I think. So I've been here, about 5 or 6 years now.
And do you lease as of today, or do you own?
I did. Yeah, I did. I really wanted to own. I think from a business standpoint, it probably makes more sense, but it just depends on your community and like what's available. And so, yeah, I really didn't have many opportunities that I saw were worthwhile in terms of an investment. So I would have almost had to buy land and build a building, and wasn't quite willing to do that. So yeah, I'm leasing right now, but it's, half a mile from my house. So I walk to work most days when I'm not being lazy, and I just couldn't pass up that opportunity.
Well, you can't be lazy, because the whole summit, you're like, where's Ryan? Oh, he's biking or he's on stage. So that was
no, that's because I'm by nature an introvert, and I need a lot of alone time. So I have to get away, and it's hard for people to find me if I'm on a bike somewhere in Minneapolis.
Oh man, I love it. Let me ask you, because I think back to Dr. Delicia Haynes when she shared about how she has experience in interior design. And one of the things that she wished she had even more and more of all the time is space for storage. So when you opened when you moved to your new space, were there certain things where you're like, I must have these particular things in addition to just more physical space?
Yeah, honestly, in retrospect, I've probably always had too much space. In fact, I probably have too much space now in terms of just, because storage is stuff that you're not going to access that often. So I probably in both settings have had almost too much space. I mean, it depends on the day, but no, I've never felt like I didn't have enough space. But yeah, I think, designing your own clinic space is really fun because it's not something that most doctors get to do. They just show up to work and it is what it is. And so just your kind of ability to put your own personal touch and flair and kind of your preferences in there, I think is super cool. And it reflects you as a person and your identity. And so, and that's going to take different forms. I'm kind of more minimalist, modern, whatever you want to say. But, I have doctor friends who are exact opposite. Their communities are exact opposite than that. And so, they kind of have a country theme or whatever, and they both work. So I think our physical space can be these cool reflections of who we are. And so you don't almost ever see that in a traditional practice. They have like the standard clinic wallpaper, that is the same somehow across all of America. So I think DPC can be much more creative and artistic than that.
My favorite, and I'm getting very facetious here, is the stick-on carpet tiles where they've moved so that you can see the little gaps, and those are not important to address or fix or care about. But I would always comment like, well, this looks like you don't care about the clinic, because it's really hard to, I digress, but that's my facetious comment about fee-for-service clinics. They're my favorite.
Yeah.
So when it comes to Ashley and Jessica and yourself, even though like you and Jessica have separate panels, when it comes to like moments in time, like, the pandemic, or when it comes to like, if kids are coming in for sports physicals, how do you guys at times collaborate in your practice to, to like optimize workflows or get things done quickly?
Yeah, I mean, it depends how busy we are, at times, but we, by design aren't too busy most days. But yeah, I mean, I've always tried to foster, even though we're really tiny. It sounds funny to say any of this when you're so tiny, but we always have students here. I mean, I have medical students most of the time, and I have pharmacy students sometimes. So we've always just tried to foster like a learning environment. And I know that sounds cheesy, cliche, whatever, but like we're always just talking about our patients and something interesting or something challenging. So it's kind of just like this open dialogue. And so, for us, it's just kind of part of the day, so we call it like collaboration, but it's not like my mentor in residency where I had to go set and present the case to them, So I think my nurse sometimes is interested in this stuff as I am, and so, one of my nurses ended up going to medical school, another went to law school. Yeah. So I think we've always just done that here. And so when you have more time with each patient and more downtime, like I think it's just natural to kind of learn more about something, right? Like we're one of the new medications for atopic conditions, Dupixent. I can't remember the name of it. Anyway, we haven't really used that a lot, but like we have a lot of patients who still struggle. And so we've had a couple of patients start on that recently. And Jessica has major severe eczema that just can't be managed any other way. So, they did see a dermatologist at one point and didn't really stick with the medicine. So we figured out how to get them the medicine for free. And that's like a stupid expensive medicine, but they were uninsured. So we got them this like $2,000 a month medicine. And I was like, I've heard of this medicine, but I don't really know. So we just sit down and start reading about it. And it's like, oh, maybe it's actually lower risk of side effects. And, we look up the monitoring parameters and stuff. So that's kind of like it's always just us trying to learn more. And sometimes like I know more about something, and sometimes maybe my nurse knows something, about something that I don't know about. And so that's kind of how we just approach it. It's just a natural learning environment. And hopefully we all get smarter with time.
That's a good goal. That's definitely a good goal. When it comes to the fact that you've had multiple nurses join your practice and then, branch off into other life, how do you hire? How do you hire people at your practice?
I wish I could give some magic here. I've just gotten lucky, to be honest. When I hired nurses, I didn't get like a million applicants, so I didn't have a ton to sort through. But really for me, like when I was in that process, like one or two every time I had to hire someone stood out based upon the initial email or their resume or whatever. And so I've just gotten really lucky. I know other doctors, this is a big struggle. This is not unique to DPC, but being an employer, oftentimes the hardest part is hiring reliable people. And so I've just gotten really lucky, and we've always had good employees who showed up and, we're really, really smart and caring. The worst thing is when they leave, but that comes with the territory, right? If you find someone really good, there's a chance they're going to leave. So, that's challenging, but that's true of every business and business owner, as you find someone who's really good and reliable, and then you have to eventually replace them.
And for the transitions that you've experienced at New Care, how have you documented your workflows so that a new person can start without you having to retrain everybody?
Like I said, I got good people. They trained each other. Like, I mean, I really didn't. That sounds strange, but obviously when you hire a new person, there's some things they don't know about you and things you prefer, but my nurses have always been really good. And then, they gave us fair warning when they were going to leave, and they started writing stuff down and pass it to the next nurse. And then they worked side by side for a few weeks or a few months. And by the time the other one left officially, and some of them even kind of like worked a little bit after they left just to kind of touch base. And so they took their job, I think, serious enough that they didn't want to just drop the ball. But I've just gotten lucky. That's probably not something you can always guarantee. So I actually probably haven't written down that much. The nurses have like something they've written up and they share with each other. And then, we've had other like part-time nurses or PRN nurses. And we have another part-time PRN nurse right now. So you have to kind of, people who aren't here that often, we have like some guidebooks and manuals, but
I'm sure you made a lot of people jealous in terms of the luck you've had with staffing, but also the fact that, they're helping each other maintain the quality of care at your practice without gaps. And I think about Dr. Nick Thompson and Dr. Brandon Ullman, who are in Kansas in another different part in Wichita. They were talking about how one of their nurses is working remotely. And so just something to think about if you have a staff member who's moving and they're willing to help, train the next person.
We do that still. Yeah.
Yeah. That's great.
Sometimes it's like really challenging just with everyone's, lives and work schedules. And so, yeah, we've done that. Like when both nurses have been unavailable and like, I'm like, okay, can you, wherever you're at, do you have access to the internet? Like, yeah. I'm like, okay, you can just log on for like 1 hour in the morning, 1 hour in the afternoon, check emails, make sure we're not getting behind on those and voicemails. And so, yeah, they're self-starters. So that's my, biggest piece of advice is find people who are self-motivated and self-starters. And, not that you don't need to have some direction, but if, it's like my children, I tell them like at some age, like you don't need me to give you a 7-point process. If I say, clean your room, clean your damn room. Like if I need to give you a 15-point checklist that, past a certain age, like that's a problem. So yeah.
Self-starters. It's a good takeaway. I love it. So you had us all, like, I suspect that everybody was tearful at the DPC Summit. You did
my
crazy
fitness presentation. That's
yes.
For those who didn't attend, they're going to be like, what? Yeah. Didn't he talk on fitness? Why is he people crying?
Yeah. So you did a talk in the 301, so it wasn't recorded, but the slides are available. But it was just incredible because the opening, commercial video that you showed was really getting at the heart of why we're all doing this. And in that particular lecture, you were talking about fitness and you weren't talking about lifespan, but you were talking about health span. And so you have opened FitnessDX as, as an extension of New Care. Can you start us off by telling us what is FitnessDX and how does it differ from New Care?
Yeah. So from the beginning, I have always in my practice, and I think in my training, and maybe even going back to when I was younger, recognized that, quote, lifestyle, which I actually hate the term lifestyle, but, I say it with quotation. So that lifestyle is important. And I think all doctors know this, especially as you go throughout your training and see the manifestations of people abusing themselves with, tobacco or alcohol or whatever. And obviously poor diets and sedentary and all this stuff. We know this, I think. And so I've always emphasized, I think most people in family medicine, that's probably the one specialty that actually emphasizes it. I know other specialties, no offense to them, but it's a tiny percentage of what they do. They just wait for people to get terrible things and then fix them. And so I think by the nature of being a family doctor, we get trained in that, but I don't think we actually understand it very well. So I will say from the first day, like I've emphasized prevention and, quote, wellness, lifestyle. But, as the years went on, I had become increasingly convinced that unless people do better with that stuff, my powers are just very limited. And I think all family doctors feel that way. That kind of fatalist perspective is natural because people are coming to us. And even if they come to us religiously every year to get their, quote, checkup, their lifestyle, their inactivity, their smoking, whatever, is so terrible that there's nothing we can do to avoid that kind of cliff. Well, cliff would be the better outcome for many people. Again, I'm a fatalist. So that slow, miserable decline that we see coming, right? We can see it coming. We try to warn them, but it's, it seems like we can't, keep them from that sad fate. And that sad fate is not a quick death. Like I said, it's that suffering and that misery that happens in the last 10 to 20 years of so many people's lives, that end up, losing their independence and their autonomy, and they're frankly unhappy. And I would be too. And so, despite all of the miraculous things we can do in medicine, testing, screening, medications, the reality is most things we do in medicine do not really improve that health span, which is the number of years you live at a functional high level. We might be able to extend life a little bit. I know life expectancy is viewed as this like, oh, this country is good and this country is bad because they live 79 and they live 81. And I'm like, well, I mean, to me, that's always kind of fell short of defining our goals, right? So I think that's just been my like increasing experience as a doctor is that I feel like if we don't do better educating people or helping people with these topics, that we're maybe extending their life, but kind of for a miserable existence. And so, you can take any part of that you want, but to me, I think it's pretty clear that activity or physical fitness is the most important of all of them. The more research you read on this, it becomes very clear and apparent. So I know there's probably more people in the primary care world or in the DPC world who are super fixated on nutrition, and they fly some flag of whatever, brands. I'll try not to offend people in this talk. I did, I'm sure, in the summit talk. But and it's not that I don't view those things as important. And clearly the standard American diet is terrible. But for me, I kind of came to the conclusion that without physical activity and improvements there, like our society and culture is doomed. I think we will continue to suffer the same sad fates. So yeah, so that's kind of where my headspace was at probably 4, 5, 6 years into practice. And so, I continue to explore those topics, because the reality is even though I'm a pretty active person and ran college track and field and tried to stay in state my shelf, I probably wasn't in that good a shape because being a small business owner, that's hard. But just started like exploring that, like just started reading a lot more and going down so many rabbit holes and realizing that, man, I didn't get any real education on these topics, and the science is super fascinating with a lot of this stuff. And so just kind of like in my own personal journey with that and helping some patients through with it. And then, I have a few patients who are like actually competitive, athletes, trying to help them, accomplish their goals, which is super fun. And just decided that, I need to do this better. I need to kind of create a service for people that goes beyond what you would call traditional prevention, but it's very time consuming and can be expensive. Some of it can be. And so I decided, probably 4 or 5 years ago that I wanted to kind of launch this fitness testing counseling service. And, I kind of started gearing up to do that and bought some equipment. And then, then the pandemic happened. So I kind of had this brand, this cool idea. And then, end of 2019, is that when the pandemic started? Yeah. And so I kind of just put it in the back burner because I'm like, oh no, no one cares about anything except for this one virus. So I continued to do a lot of it kind of in the background, but then decided if I'm going to really do it, like I have to create a separate service and brand for it. So I launched FitnessDX earlier this year, and it's hoping most of my patients, if not all of them, do it. But so our patients, get a discount for it, but it's open to the public. So we took like one big room in our clinic to put some equipment, some testing equipment and stuff in there. So yeah, it's the way I tell people is it's a way to diagnose and monitor your fitness as well as get some really good feedback or exercise prescriptions. There's no silver bullets. It's funny when I describe this to patients and sometimes doctors, they're like, so you're doing hormones or something? I'm like, no. So it's I'm still trying to navigate like how to present it. But I think we have like a really cool, website with the descriptions of the testing, but it's some of it's pretty, in-depth scientific stuff. And I'm trying to figure out how to translate that into, general population.
I love it. And somebody asked during the lecture, what made you decide to carve it out as a separate service versus include it with your membership?
Yeah. And time. I mean, so the rate limiting step in providing primary care is time, as everyone knows. So, my fees are super affordable. I think our average is, with family discounts and stuff is like near $50 a month. And so some of this fitness testing is quite labor and time intensive. And so, depending on what the person's goals are, they might want to do it a lot. And there's no way we could provide the level of testing and counseling under this. So I still emphasize it. So even if people are not doing the fitness testing, I still probably spend half of my time in their yearly preventive visit talking about these things and giving as good a direction as I can to them. And then some like really, I think, good emails and stuff about like, here's what you should do. And then I say, hey, if you want to dive deeper and get more feedback about your current level of fitness. But, I've joked for years, even back at the beginning of my practice that, you have these patients who come in every year for their checkup, right? What's my cholesterol, doc, compared to last year? Their LDL goes up and down, who knows, sometimes random. And they're trying to use this as like a proxy for how healthy they've been over an entire year. And I've always known that was just a little bit silly, right? And some of these people are like clearly struggling, right? They're 52 years old. They can barely get out of a chair and they're worried about their LDL. And not to say that LDL is not important over the next 30 years of their life, but like, I'm like, they have like a clear and present problem and, they can't walk up a flight of stairs yet they were fixed on the LDL. So I've always joked, and I have actually offered this to many patients. I've only had a couple take me up on this. I say, I don't really think it's going to be that helpful to check your cholesterol once again, for the 50th time in, 10 years or whatever. Let's just go walk up this hill right here and see how you do. And they're like, what? And I'm like, well, that would tell me more than checking your LDL yet again. And no, I just want to see what my cholesterol is doing, Like I think what patients are desiring from doctors often is they want, like when they say they want to check up, what they mean is do I not have a problem, or like even more so like a prediction of the future, right? Like I think we don't think of it like that, but I think people are like, they want to go back home and tell their spouse or their family, hey, I got my checkup, everything was fine. And I'm like, that doesn't, it falls so short of understanding human health. So I've always joked that I would much rather, if you made me pick, I would rather walk them up the hill near my office and see how they look rather than doing their labs or vital signs or anything like that. So,
and I have no idea, how CMS would code that and represent, the visit of walking with your doctor up a hill, even though there's a code for
I think that's really,
post.
yeah, if you want to get really into this, like the perverse incentives in our medical system, in the traditional, CPT reimbursement driven system are really the problem. I think, like, if you watch my presentation or any other doctor's presentation about this, if you look at what matters in terms of health outcomes, these topics that I'm talking about, someone's cardio, respiratory fitness, their skeletal muscle mass, their strength, there's so many other functional measurements that are so much better at predicting health outcomes than the things we measure in practice. And it's like, well, why don't we do that? There's no way to code and bill for it. I mean, there's so many things in medicine. And I think that about so many things when you look at people in DPC doing things outside the box. I'm like, well, why did they figure it? It's not like, no offense, but we're not like geniuses. We might be average at best doctors, but we discover things because we're not trapped into, can I code it as a 99213? And if I can't, then it just doesn't, we don't do that. So yeah, I've often thought that like we miss so many things that are important because it's not a codable service. So I don't know. I mean, and I think if you step back and look at health and public health and, the broader problems that poor American health pose to our economy and our civilization, our culture, like these things matter more than many things we do and pay a lot of money for in medicine. So, bang for your buck, it's kind of a no-brainer. But again, our medical system, it's just like, well, we have medicine and then we have health. And then health is like this weird thing where you have trainers and stuff, and no offense to trainers, but, we need to have some recognition that stuff is as important as anything a doctor does. Not that you need a trainer. I'm not endorsing people needing a personal trainer, but yeah, in terms of health and outcomes, like it's very clear that stuff matters more than most of the things that doctors do.
Well, it makes me think about, we have so many patients, especially in primary care, where they come in for their Medicare wellness physical, and they're so shocked to this day where it's like, wait a minute, this is the visit where you can't touch me or listen to me. And it's like, yes, that's correct. This is the talking visit. And then we even had a patient come up to my husband and I when we were walking one day. He's like, well, Dr. Fowler, I'm going to cancel that appointment because I think it's BS. And my husband was like, so do I. So I'll see you at your actual visit when you actually have a problem. So it's pretty crazy that,
Yeah.
When it comes to, again, I love how you use health span versus lifespan. And you made a very good point. Graphically, you had two pictures up on one of your slides at the talk where it was like, here are three people and they're like, they're older people, gray haired in their jogging suits, like going on a walk with a dog. And then you have the lady who is decrepit in the hospital bed. Yeah. And so it's really like, I think it's so empowering for a direct primary care doctor or a direct specialty care doctor to be able to, like, I think about like Dr. Nicole Harkin, she's a freaking cardiologist and she's talking about preventative cardiology. Like we do prevention on such a different level because like you said, we have the time to do it. Like I had an hour and a half conversation with a patient today just about prevention and about, horses versus zebras. Let's check and make sure all the lifestyle things are optimized before we start going after the things that, you could invest lots and lots of money and time on. But I think it's so awesome as a DPC doctor, as a direct specialty care doctor, to be able to have that time, like you've pointed out. So I love that. Now, when it comes to, you mentioned this, how you have kids, you have 4 children. And so I wanted to ask first, where along your DPC journey did each of your children join you?
Well, yeah, in terms of like how old they are now. So my children, I'll butcher this. God, I hate, when you get this many kids, you actually have to like stop and think about it. So my oldest is 13 and my youngest is 6. So yeah, my first child was born my first and second kids were actually born in residency. The second one right before I started. And then the second 2 were born after I started my practice. So yeah, they're all pretty bunched up together. And yeah, I think no matter what career path you take, having children is a ton of work. So, but being a small business owner and starting a business while having a bunch of small children was very, very stressful. But again, I think that's true of no matter what path I would have taken. But there was a couple of years there where it was very, very hard. I think on my wife and on me to be, moonlighting full time and trying to start a business and being stressed about that. So not for the faint of heart to have 4 children while starting a crazy business idea straight out of residency.
And as you, went through life with one kid and then another kid and then up to 4 kids, do you have any things that you learned to help keep peace at home in terms of stress levels down, or hacks to be able to be present for your kids as you were continuing to delve into entrepreneurship?
I mean, other than contraception, right?
Love it.
It took us a while. We were like, wait, you can just not have this happen? Yeah, it took me way too long. I slept in a lot of medical school lectures, and my wife's a pharmacist, so she should have known better, but whatever. Yeah, I don't know. I mean, I'm not one to give advice on these things. For me, and I think my wife probably to a lesser degree, like carving out time for ourselves, is super important. So we definitely are arranging, according to my neighborhood, free range children. And so the more kids you have, the more you believe in such a movement and idea. And so we've tried to let our children be very, very independent, as soon as that was safe and possible. So I think that really helps. But then, trying to get time for yourself, whether it be totally by yourself in my case, because I'm an introvert, my wife's opposite, or together, I think that's super important. So we've always tried to do that. And we've tried to not let kids slow us down. I heard so many people, we had kids, I guess, relatively young nowadays. It seems like if you have kids before 30, people think you're young. Oh my God, you had kids at 26? That's like super young. I'm like, well, my mom had me at 18 or 19. So I don't know. But yeah, we've always tried to say that we weren't going to slow down our lives because of our children. I think so many people said that, and we were like, but you can just take kids on a plane. You can take them anywhere. So we continued to travel. We continued to live our lives. We weren't going to put our lives on hold because we had children, because then I think you kind of end up presenting them, especially if you like travel and doing, fun things. So we've done some crazy things with our children over the years that most people are like, are you insane? You took your children where? And I'm like, I don't know. I mean, we have kids and we wanted to go there. So we just, took them. So I think that's my best advice is just to keep living your life and continue to be active and continue to travel. And, I know that can get expensive, especially with 4 children. So that's what we've always said is we want a lot of kids, but we don't want to act like we have a lot of kids, if that makes sense. And it's hard to have the best of both worlds, but I think it's possible.
Absolutely. And I think that the fact that, like you said, there's a way different presence of DPC in the nation than there was when you opened. There's lots and lots of us who have kids and are still practicing. We didn't perish because we gave birth, so it's
Sure.
you can do both.
Yeah, and obviously differences here between men and women. I know women, that's much more complicated in terms of especially the first year or two of your kid's life. So yeah, my nurse practitioner Jessica had, I think, a kid 3 or 6 months after she joined here, and I knew that was going to happen. And so that obviously was much more difficult for her. I just come home and be like, they eat well today. Okay, good. I'm going to bed. So I definitely, as a dad, really can't say that anything is hard compared to moms.
Well, I love, I think about when you talk about Jessica having a baby while practicing, I think about Dr. Jennifer Allen, how she has the little ones just come to the clinic. They're quiet. They literally don't fall over. We know when you put them in a place, they stay there.
We have kids we have our own kids here quite often, especially in the summer when school's out and stuff. But my kids, they're elementary school. My 2 younger ones who are still in elementary school. My practice is almost exactly halfway between my house and the elementary school. So they literally walk by my clinic, and 9 times out of 10, they stop by and steal our snacks and get a drink and complain that it's hot outside and I have to shoo them out the door. But sometimes I'm like, whatever, we'll throw on a movie on in the extra room there. And so I often come in and my nurses give them a bunch of, treats and stuff. So it's great.
I love it. Now, when you talk about one of your, hacks to keep yourself and your family balanced is respecting time for yourself. I want to go into the idea of burnout, because whether it be thinking about how you are present as a parent or how you are present as an owner, how do you look at burnout and how do you look at prevention of burnout when you're a DPC physician?
Yeah. Number one, I hate the term because I think it implies that there's something wrong or weak with the person who's quote burned out. So yeah, no, I'm not putting that on you because I know that's the term that we use, but I just hate it. And I think it kind of implies that physicians are not resilient enough or tough enough to kind of deal with whatever is required. And I think that's mostly garbage, because I think most of my friends who got into medical school and like were really hard workers, were really disciplined. And I think we're able to deal with a lot of stress, maybe more than the average person, although, I know everyone has stressful lives. So I think there's two facets to that. I think within the regular medical system outside of DPC, I think there's so many moral hazards in medicine, and people have written a lot about this. There's so many good people who spoke and read about that. And I think the healthcare system so discourages actual health and the practice of medicine that makes complete sense to why people would be unsatisfied, unhappy, unfulfilled, and feel in some respects unethical because they are trapped in a system that treats people so poorly. So I think when you look at the larger healthcare system, I'm like, well, no crap that so many doctors are sad, depressed, suicidal. In DPC, it's still a real thing, right? Like, I think we need to talk more about this. I've talked to a lot of my friends privately over the years about this. And so, even though we've kind of escaped this terrible healthcare system and able to create this kind of idyllic, version of our practices, it's still super, super stressful. Being a small business owner is stressful. I have a lot of patients who are self-employed, and you worry all the time about, whether your business is going to succeed, even if it's 10 years old, even if it's 20 years old, I'm sure, even the most successful businesses still worry about that, because no one's guaranteeing you a paycheck. So I think being a business owner just comes with inherent stress. So yeah, I think that's true. And then I also think DPC, if there is a dark side of DPC, it's because we get to know our patients so well and so intimately, which sounds like on the surface amazing, right? Because you can spend an hour and a half with people, you spend so much time with them. The downside of that is when, patients still struggle, right? Like I feel that way all the time. I'm like, I've given you everything I have and you're still not well. You're still not better. I've used every tool. I've thought outside the box, and maybe they've seen 10 other doctors too. That's usually the case. And they're still not well, right? They still suffer a lot. And I feel often powerless to fix them, right? I feel like we feel like we're healers. And so they should be well. And so I think because we get to spend so much more time with people, we get to know them better, their whole story. And that becomes even more challenging when people don't do well. And sometimes, we are powerless, right? When people die of, stage 4 cancer, I think we recognize that. But, when we're dealing with these more kind of chronic illnesses and stuff, and people continue to go downhill and suffer, I think that definitely has a toll on people. And it does me. I think that's part of my increasing emphasis on fitness, is that I'm like, well, the only way I can reduce misery is that, right? Like, I can't prescribe you enough pills. I can sedate you, at the end, and the end can be weeks, months, or years, depending on what you want. So that's probably part of my emphasis of that has been, maybe it's a way out of that, or I think it maybe is at an individual level, maybe one of the ways to reduce misery in life and increase happiness. But yeah, I mean, I think we definitely need to talk about that. And DPC isn't, some complete unicorn where everyone's always happy. And it's true that a lot of us are still burnt out at some level, and human, just dealing with humans, right? Like, it's very taxing and emotional to deal with people who are difficult, stubborn, rude, so we deal with that every day, and we vent like none other here, behind closed doors. And I think that's healthy and normal for us to do. But, that's hard to talk about publicly because, that comes across as negative or not, caring for people, but it's definitely part of the job. And I think we need those kind of safe spaces, maybe to vent to each other. You call it the doctor's lounge or nurse's lounge or whatever, but some people are just mean. That gets old.
It totally does. And if you're going into DPC, I think it's something to be very aware of. Like, I love that there's usually lectures on the dark side of DPC at whatever summit you go to. But I think that, just calling out specific episodes of the My DPC Story podcast, Dr. Whitney Webster Pack was a pediatrician at the Four Corners in Colorado. And she shared how her practice was very limited because she could not take Medicaid patients in the state of Colorado. And there was no other pediatrician around, and her practice closed, but she's still alive. She still is very proud of her DPC experience. And then look at Dr. Erica Bliss. I mean, Dr. Erica Bliss, one of the original pioneers with Dr. Garrison Bliss, who soared at Q Lions, and Q Lions is no longer, and now she has Equinox. And so, when it comes to talking about DPC and the experience of DPC, I've definitely, encouraged people to realize that, like, this is going to come out in a later episode, but I was having a conversation with Dr. Amber Beckenhauer, how, like, I was crying to Haley Miller one day, who owns Mountain States Diabetes. I was like, Haley, and she's like, oh yeah, no problem. I was there exactly 3 months ago. So you keep crying. I'm going to give you empathy as you cry your tears out, because you got to do that. And then we will go on to the next day and do the next thing that we need to do. And so it is not always sunshine, lollipops, and rainbows. And I'm so grateful that you mentioned that,
Yeah.
because people need to know that it has its ups and downs, but overall it is flipping
Yeah.
amazing. And like, I'm just like you, I will not go back to,
Yeah. Which it's trading one type of stress for another, right? Like I think in the normal system, we have those moral hazards, which are like inherently built in, and deep down, we kind of feel this lack of self-fulfillment professionally, personally, and otherwise. And like, and not saying like some people can't just kind of put their head down and be okay with that. Like I have many friends who do, and I'm like, awesome for you. And they think they're providing great care, seeing 38 people a day. And I'm like, I don't know how you do that. I feel like an idiot because I care for much less than that. And I feel like I sometimes let people down. So, so I think there's the normal system stress. And I think that stress is kind of baked in, whereas DPC stress is a different type of stress. But at the end of the day, you tried your best. You could give people what they needed. And there's other things that may not be great, right? It might be just the person themselves and you have a personality conflict, or it might be business problems themselves. But I think deep down, like you feel like you're doing the right thing and that you have a path to, self-fulfillment. I sound like I'm giving some kind of weird, Tony Robbins speech here, but I don't know. But I think it makes sense to most of us.
I agree with that, because, the people listening are for the most part thinking about their own experiences. Like I think about even the quote you had from your 2012 Kevin MD article that, if you didn't wish to live in Groundhog Day every single day. And there's people who, no matter how you try to escape the fee-for-service world, devaluement, stressors, fill in the blank here, when the system is so run by, well, I have to take it to 16 administrative committees before we can actually make change in your clinic or your life, or you don't actually matter. You're just here to process the codes for us. It can be very disheartening. And so people, I'm sure, are listening to your words and thinking of their own experiences. So going from that note to an inspirational note to close out our talk, when you think about people leaving the DPC Summit and going forward, because you've spoken at so many DPC summits and you've spoken, to so many people in the national media scene, in your local communities, when you think about where DPC is going in the future, and as people think about their spot in the DPC ecosystem, what words of encouragement do you have for people who are, really, really wanting to do DPC, but are just not sure as to when to make that leap?
I think if you're not in DPC, but you're a family doctor, primary care doctor looking at doing this, I would say, going back to the most encouraging thing, is that we have a big community of people who can help you. That doesn't mean it's going to be easy because it's your thing. So people who think this is like a turnkey thing, or if they get sold as a turnkey solution from somebody, that's probably not part of your tribe or community, or at least not the one you want to be a part of. So, but there's so many good resources, like all of your podcasts. I haven't listened to all of them, but I've listened to quite a few. Are great. And, the Alliance, DPC Alliance, the DPC Summit Conference, there's so many things out there now, the Facebook groups that allow you to learn about DPC. But at the end of the day, like, it's a personal decision, commitment. You can be passionate about anything. It could be pizza, can be primary care, but you have to make it yourself. You have to make your own, universe, where you're at. And that's scary, super, super scary, I think, for most people. But you have to decide, is that work and is that risk worth the potential of a better life and a better profession? And I think for most people, that answer is yes, if they're being honest with themselves. But if you're not ready to do that, then don't. I think I've seen many people, like, quote, take a leap of faith, but they weren't willing to put in the time and the efforts and the planning to make it work. So I some respects, I've been saying, oh, take the leap of faith. And I'm like, well, yeah, you ultimately do, but you'd better have a really good plan and a really good support group around you. And if you do that and you have that in place, that you'll probably succeed. Nothing's 100%. If being an entrepreneur was 100% successful, then everyone would do it, right? Like everyone who worked at a pizza shop would just open their own pizza shop and make more money and be the boss. But it's you have to recognize that there is some risk in doing something like this. But if you have a good group of people around you and a good plan, it's a really high chance that it's going to work. It's going to be a lot of work, but it's probably going to work and you'll probably be fine. But that's ultimately what it comes down to, is every doctor who wants to do this has to make that decision and come up with a good plan. But it's much easier now, I think, than it was in 2011. So I think you had to be crazy in 2011 to try this, but you only have to be like a little bit crazy now. But I still, in my own universe, people call me crazy, but I'm sure doctors starting this now will still be called crazy, right? So I like to think of myself as special, but it's probably the same thing starting now as it was in 2011. And the only people that really matter are the potential, 500-600 people that you need as patients. No one else really matters.
Amen. And that's why I'm so with you when you opened this whole interview with that this is the way, and this is not the way, like in that we wear Mandalorian helmets and we don't take them off and, unless we're eating. But yeah, I mean, this is the way that we have returned to the old way of doing medicine and are collaborating together to bring this to everyday Americans, this way of accessible, affordable, incredibly high quality care. And it for me, it just makes me so proud of each and every one of us who are learning about DPC, doing direct specialty care, because I always say, like, this is allowing us to be the doctors we went to medical school to be. So with that, thank you so much, Dr. Neuhofel, for joining us today.
Thank you.
Next week, look forward to hearing from Dr. Shannon Scholl of GastroDirect in Raleigh, North Carolina. If you've enjoyed the podcast and you haven't yet done so, subscribe today and share the episode with a physician you may know who needs to hear about DPC. Leave a 5-star review on Apple Podcasts and on Spotify now, as well, as it helps others to find all these DPC stories. Lastly, be sure to follow us on social media. If you're wanting to continue learning more about DPC in the meantime, check out dpcnews.com. Until next week, this is Marielle Concepcion.